patient had no complaints of diminution of vision or pain associated with the swelling. There was no associated congenital abnormalities or any systemic illness. On examination, the visual acuity was 6.6 in both the eye. The swelling was well localized, measuring about 2.5 into 1 into 1 centimeter in the left upper eyelid, extending posteriorly into the superomedian quadrant of the orbit. There was bluish discoloration of the overlying skin. The swelling was soft and cystic, with fluctuation test positive and transillumination test negative. There was no impulse on coughing or bending forward. No bruit or thrill was present. The swelling was not reducible. Eyes were orthophoric with free and full extraocular movement. There was moderate mechanical ptosis present. We investigated the patient. We did a contrast MRI which suggested us that the swelling could be a cavernous hemangioma or an AD malformation communicating with the superior ophthalmic vein. A digital subtraction diagnostic angiography was done. This confirmed us that the swelling was an isolated mass without any communication with the major artery or vein. The patient was taken into the cath lab after investigation and anesthesia fitness. Here, through the femoral artery approach, we injected the dye into the internal and external carotid artery, and we saw that the mass was not delineated. This proved us that the swelling was not having a communication with the major arterial vein. Then the dye was injected into the mass, which isolated the whole mass. These are the pictures of contrast CT scan, which is showing us the mass. After confirmation of the mass, angiographically, angiographic guided, we punctured the mass and injected a 3 ml of sodium, 3% sodium tetradecyl sulfate into the mass. The mass reduced in size 1 week post-operative. Repeating the same procedure, a second injection of sclerosant was given at the interval of 6 weeks. Post-operatively, the mass reduced to measure around 1.5 into 0.5 into 0.5 centimeter. These are the contrast pictures of diagnostic angiography. Which shows, the first picture shows us the dye into the arterial system. The second picture shows the dye which we injected into the mass, which isolated the mass. And the third picture shows us when we had put the sclerosing agent into the mass. The patient is doing post-operatively well. The mass has decreased in size. The patient has completed the whole course of treatment. This is the pre-op and the post-operative picture of the patient. As we know, we can classify the vascular lesions of the orbit into 3 main types, that is arterial origin, venous origin and lymphatic origin. Arterial origins are basically treated with embolism therapy, whereas venous and lymphatic, that is the low flow malformations, are treated with intralesional sclerotherapy. Various types of sclerosants are used. 3% sodium tetradecyl sulfate and polydacinol is the main used in orbit and head neck face malformations. Others are chromated glycerin and hypertonic saline. The main reason of us doing an angiographic guided sclerotherapy is basically, first, it helps us to prevent an accidental ingestion of the dye into the major vessels, which can cause subsequent thrombosis and fibrosis. Later, and the next is extravasation into the surrounding tissues, which can lead to inflammation. Thank you. To follow up, but
to give injections till it disappeared completely, or
our plan was to give. The child was only 6 years of age, so we had consulted an intervention radiologist, and he suggested with 2 doses the size should decrease optimally, but we would wait and see after 6 months, and after which we decided the third injection.
What does literature tell you? What is
ma'am, the literature says that in the vascular lesions, intralesional sclerotherapy is not yet studied in detail, but it is mainly done in lymphatic origin. But 1 or 2 cases have been reported where intralesional sclerotherapy is given, and the mass has reduced considerably in size, but not completely disappeared. And even our motive was to decrease the mass in size so that the mechanical ptosis can be treated first, and cosmetically the patient is.
So you could not. Globe was showing early phthisis with with a little bit of thickening of the sclera.
No, ma'am.
The vision remained okay.
There
was no side effects.
No side effects, ma'am.
Don't you think the globe side, because of the positioning of the child?
Yes, ma'am. Here it's because of the head tilt.
But it's a little bit of unusual scleral thickening. The one to the left axial?
No, actually it's mainly because of the head tilt. Because
see, Yeah,
had
that is
done
fine. The
a
size is
MRI.
fine because that, but the thickening of the coats,
Right.
some inflammation of the coats.
No, ma'am, there was no positive finding.
Dilated fundus had been done.
Yes, ma'am. The fundus was normal. No other.
Just make sure if they come back to just look on
Sure.
it.
Thank you, ma'am.
From rabbits. Of the 12 animals, at least 6 died. Severe toxic effects by this, the inflammation that is caused
By which?
Nobody.
by the sodium
But it depends. Where did you inject it?
See, they wanted to try this as a sclerosing agent for a appendectomy. This is a different study altogether. But the particular sclerosant that is used causes intense inflammation. If she's not had a follow-up study done for the same patient, we should check the patient 3 weeks, 6 weeks, 3 months.
So just see whether this agent caused that.
Ma'am, we had a 6 months follow-up with the patient.
Or it'll be post-op
yes,
MRI?
we couldn't document that because the patient had done the CT scan outside and then he failed to follow up. But then it
Was there any inflammation?
No, ma'am.
See, no more failed to follow up. Call the patient. Go to their house and bring them and do it. Yeah, in Ujjain you can do it.
Ishan has done a very big study on this.
Capillary hemangioma.
Yeah, and as far as this point is concerned of inflammation, actually we have to make sure that where inflammation is there, we should not inject because that is very, very important because that induces the inflammation. Number one. Number two is that we have after injection, we have to make sure that we have to press this site. Otherwise, if you are injecting anyway inside the mass, which is consists of basically vessels. So we have to make sure that we have to press it. That is also one of the correct method because otherwise it will not have an effect. So that is also that to be shared, sure. So that if the tumors are mass which is deep actually, where you cannot apply pressure, we should not inject it because otherwise it will lead to profusely.
Point taken.
But they did initially say that it was not it wasn't connected to any other vessel.
Yeah.
Yes, the same point, ma'am. The main reason of presenting this case was to highlight the use of diagnostic angiography guided intralesional sclerosis.
Then you should concentrate only on that.
Yes, she did. Okay, that was a nice presentation. We will now call Dr. Aditi Pujari for her paper on clinico-pathological profile of patients undergoing orbital exentration in tertiary eye care center.
Good morning, everybody. I shall be presenting our work on clinico-pathological profile of patients undergoing orbital exentration in tertiary eye care center. No financial disclosure. As we know, orbital exentration is a destructive surgery with removal of entire contents of the orbit, and it's generally the last alternative treatment modality in patients. The common indications are orbital involvement by unresectable malignant tumors, but rarely it can be advised for painful or life-threatening orbital inflammations and infections. The malignant spectrum includes eyelid malignancies, pagetoid spread of malignancies over the ocular surface neoplasias, extraocular extension of the intraocular tumors, as well as primary orbital tumors. These are few rare non-malignant causes which need exentration, and these are rare relative indications where exentration may be advised. So the aim of our study is to describe the clinico-pathological profile of patients undergoing orbital exentration. It is a retrospective interventional case series done at our center with review of records of patients undergoing exentration from January 1999 to December 2012. This was the data which was included while recording from the case sheets. As we know, orbital exentration, depending on the amount of eyelid resection, can be differentiated as eyelid sparing or eyelid sacrificing, and depending on the amount of orbital tissue removed, it can be anterior, subtotal, total, radical, or super exentration. We had total 119 cases, out of which 80 were male patients and 57 had undergone exentration for right orbits. The mean age was around 49 years. Out of 119, 47 patients had undergone primary exentration, that is, they did not receive any treatment before exentration, whereas 72 patients had received some kind of treatment in the form of either surgery, radiotherapy, or chemotherapy before undergoing exentration. The mean follow-up was 10 months. Out of 119, 8 patients had history of radiotherapy and 7 patients had received chemotherapy before exentration. Out of 108 malignant indications for exentration, 49 were conjunctival in origin. When we see the spectrum of etiologies, the sebaceous gland carcinoma topped the list of lid malignancies which needed exenteration. Out of 49 conjunctival malignancies, OSSN, that is ocular surface squamous neoplasia, topped the list of the conjunctival etiology as well as overall etiology for needing exenteration. Intraocular cases included retinoblastoma 2 cases and extraocular spread of uveal melanoma in 8 cases. This was the spectrum of primary orbital tumors which needed exenteration. Ocular surface squamous neoplasia was the commonest cause which needed exenteration in our series. All the cases were done by eyelid sparing method, and most of the cases needed just anterior exenteration because of the etiology was there in conjunctiva. Out of 48 cases, 30 had undergone suboptimal treatment before undergoing the exenteration. 24 cases had complications which included wound gape, fistula, socket infections or cellulitis in one case. There were total 24 cases and few complications were overlapping, that is infection leading to wound gape or fistula. But all the complications were wound related and none of the cases had disease recurrence because post-surgically the histopathologically clear margins were confirmed. When we review the literature, the largest case series of exenteration has been published by Bartley et al., which they had 102 cases. And as we know, basal cell carcinoma and malignant melanoma are the most common etiologies of generally the malignancies occurring in Western population. These were the malignancies which needed exenteration and higher number in that series. But a study published by Pushkar et al. From India, they had squamous cell carcinoma and sebaceous gland carcinoma as commoner indications needing exenteration. The Western studies also had squamous cell carcinoma as few cases needing exenteration, but even in them, most of the cases had adnexal or skin diseases, whereas ocular surface squamous neoplasia was not that common. So to conclude, what we can say is there is definite need of awareness about the disease in patients as well as general ophthalmologists in our country. And the most important thing is standard international protocols must be followed to avoid recurrence, which includes proper surgical technique, including the clear margins confirmed on histopathology and the cryotherapy to the clear margins and a proper follow-up and even the patient education which is needed from the ophthalmologist. Thank you.
Very good presentation.
Various other studies which have been published before.
Most of the studies and generally ocular surface squamous neoplasia is supposed to be one disease which can be just managed with excision, proper excision and reconstruction of the ocular surface. It ideally should not need exenteration, which is a radical procedure, and that is happening in our country. So something is going wrong and which needs to be corrected. Either the surgical thing, patient education, or the technique by which, or the histopathological reporting, that thing needs to be corrected.
The point to be stressed is referral in time.
Yes, referral in time and proper surgical technique, I guess, is important because out of 48 cases of OSSN, 30 had undergone some surgical treatment before they actually came to us and we exenterated them. So maybe the histopathologically margins were not confirmed or some kind of discrepancy was there.
Sorry, I missed that. Out of 119, how many were OSSN?
48.
But yeah, so your take-home message really, we cannot expect the patients to come forward. So the take-home message really is for the ophthalmologists and the oculoplastic surgeons or even the cornea. Sometimes the general ophthalmologist will be meeting these anterior.
Yes.
So take-home message is we need to emphasize it that this has to be treated better.
And maybe patient education is important because maybe post-excision, if we tell the patient that you need to just keep an eye that it doesn't recur, because recurrence was the kind of common indication where he needed the exenteration.
Yes, doctor.
So lid suturing we have done on the same setting or the secondary?
I didn't get your question, sorry. Lid sparing.
Lid sparing.
Yes.
And you showed that you have sutured the lids after cutting the less margin.
Yes.
So you did at the primary surgery or at the secondary surgery?
Primary surgery.
At any point of time inside the orbit or then they just may create a problem, because I have encountered such patients.
So when would you then do the surgery?
So see, we can wait for the.
We can always do the frozen section and then do it. So
That is not
available everywhere. No?
Yes, Dr. Sabri, before you stand.
Like the frozen section, I think, is the best way to go for extremely malignant patients.
Yes.
And the ones where we do recurrences, and we have the facility in the institute, and even
If you have the facility in the institute, yes, a frozen section, especially where you're suspecting it to be malignant, would be a good
and
idea.
malignant tumors is after the exemplation, whatever margins you've taken, send another set of separate skin and muscle margins on all quadrants.
We now have the last paper of the session, Management of Hollowing and Herniation of Low Eyelid Fat, Blepharoplasty versus Injection Fillers. This is going to be presented by Dr. Kasturi.
Respected chairpersons and ladies and gentlemen, I'll be presenting on management of hollowing and herniation of lower lid fat with blepharoplasty versus the injection filler. No financial interest. We all know that aging leads to sagging of the eyelid tissue with weakening of the orbital septum, thereby producing the classic double convex deformity. This double convex deformity is basically characterized by the lengthening of the eyelid with the prominence of the orbital rim and the herniation of the orbital fat. Thus, medially it is known as the teardrop deformity, and laterally it is known as the hollow eye deformity. So how to solve this problem? This deficient volume needs to be supplemented, which can be addressed both surgically and non-surgically. Traditionally, we know that a blepharoplasty is a subtraction form of surgery which includes excision of variable amount of skin, muscle and fat. So what is the best fit solution? This can be either a blepharoplasty combined with a subperiosteal repositioning of the lower lid fat during the procedure, or the injection filler in order to level out the perigon. So the aim of the present study is to compare the efficacy of the lower lid blepharoplasty with fat repositioning versus the injection of hyaluronic acid filler in the management of hollowing or herniation of the lower lid fat, with the clearance of medical ethics committee of the institution taken. This is a prospective intervention study of 22 patients divided into two groups, where in group 1 we had done a blepharoplasty with a subperiosteal transfer, and group 2 injection hyaluronic acid was injected, and all patients were randomly allocated to either treatment arm through a computer-generated random number sequence and minimized to 11 in each arm. So, thorough pre-operative evaluation included a complete anatomic evaluation and the injection, including the evaluation of the lid density. And the pre-operative documentation included a full face photo, the mid-face, the eye box, which is very important in documentation, especially for the oculofacial aesthetic patient, and the telephotography. So, in group 1, we had done anyway, in the group 1, we had done the bilateral blepharoplasty, wherein we had transposed the fat. And in group 2, we had injected the hyaluronic acid, which is a non-animal-based synthetic filler, which consisted of 24 mg per ml of the hyaluronic acid. It is injected deep within the inferior orbital rim. So it is very essential that you mark the area, and once you mark it, when you have to inject when you withdraw the needle, not at the time of inserting the needle. So in our patient of 22 patients divided into two groups, the mean age was 52 years plus minus 4.2 standard deviation. There were more females than males with a maximum follow-up period of 3 years. So these are some of the patients undergoing the lower lid blepharoplasty. You can see here, in every patient, subperiosteal fat has been transposed, and you could see the teardrop deformity has been taken care of. There's another lady undergoing a teardrop deformity correction with a subperiosteal fat transfer. This is the 4 years post-operative. This another lady pre and the post. This gentleman wherein a 4-lid blepharoplasty has been done with a subperiosteal fat transfer, and here we can see here, this is what we do. I just transfer the medial fat bed, excise the lateral and take the central and the medial, and then you have to put it subperiosteally. This is you can see the bolsters are being used where we use a pruning suture to transfer the fat, and these are the long duration follow-up of 3 years. So in the group 1, a total out of 22 patients, when 18 patients, there was significant improvement in the teardrop deformity. In the group 2, we did have a lower lid ectropion, and also in group 1, we had some amount of prominence because of this over-resection of the fat. This is a gentleman where you can see a lower lid ectropion following the lower lid blepharoplasty, and here because of the over-resection of the fat, you could see some amount of hollowing of the lid crease. In group 2, effective lead control could be achieved in all patients with injection filler. One patient had bumpiness in the lower lid which was hyaluronidized and was totally recovered with injection hyaluronidase. We had a recurrence in 9 patients because we know the hyaluronic acid usually lasts for 1.5 to 2 years, and we did have to re-inject in some of the patients in group 2. This is how we had injected in the inferior theatre of deformity. This is the pre and the post-injection. This is also a long duration follow-up of almost a year following injection hyaluronic acid. So you may do get some amount of bruising during the injection, but they really work well, especially in situation where you can differentiate between the fat and the fluid before giving the injection. I mentioned that in group 1, I had a patient with bumpiness. You can see here, it is seen very well in the picture to the left, where I had to give injection hyaluronidase, and this totally cured her bumpiness. So I had to do, I also do an ultrasound in all the patients, and you can see it in the first day, you can see a good amount of hyaluronic acid, and then in the course of time, this stays, but it stays maximum for a year or so. So traditionally, low-lid blepharoplasty involves the removal of the fat, and nowadays we all know that blepharoplasty should be done along with the transfer of the fat. There are numerous studies on it because we know the fat has the advantage of using the autogenous tissue. Theatre of deformity can be corrected with the hyaluronic acid, which is also an effective procedure. We did get good results in both the approaches, but the advantage in the group 1 is that it was permanent but requires hospitalization, and the other one, it needs reputation. So this is one of the first studies to address the 2 approach and to compare the 2 approaches, and thank you very much for your patient hearing.
So just one point, very nice paper, Dr. Kasturi. You said that there are, when we do blepharoplasty, we are removing the fat. When you're doing the filler, you are only injecting. So how are how are they both comparable then? If one is only subtraction.
Yeah, I got it. We used to do long time back, you excise the fat. But there we have realized that if you excise the fat, it leads to enhancement of the theatre of deformity. So what we do, we don't excise the fat, the medial and the central. We excise on the lateral. Actually, the video did not play here. So the medial fat pads, you have to transpose subperiosteally in order to take care of the theatre of deformity. But to overcome this surgical approach, we can also do non-surgically with this injection filler.
So the injection filler is only going to work for the theatre of deformity?
Yes.
So if there is prominent pads of fat on the lateral part, we are not going to address at all.
Yes, initially we used to think that yes, in aging we have a fat excess. Actually we don't have a fat excess. There's atrophy of the fat, there's atrophy of the skin and the cheek ptosis. So we need something like to go for cheek enhancement, and we can overcome all this.
So you're saying the filler just
yes,
fills in all the troughs and makes it all look smooth. Very good.
Thank you.
To present free papers. So now we end this session. The next session will start in a few minutes.
Do we have Dr. Jayant Kumar Das here? We invite you to present your talk on pesticide residues in blood and ophthalmic malignancy.
And my friends, my topic is on pesticide residues in blood and ophthalmic tumor. I have no financial interest. Pesticides are agents actually to kill the insect, foods or fungi or any other unwanted insect. Exposure to pesticides has been indicated as a possible contributing factor in pathogenesis in silent malignancy. Some studies was already done in Western countries. Many compounds banned in severely restricted in the United States, like DDT, etc., still in use in our countries. So pesticide without any quantity, nothing, barefoot, and that all pots or all are everything are in that we are nearby to the site, in the near the residence. So those are the points, and some poor people they are mixing the pesticides pot in the same, and they are using for cooking utensils also sometimes. So that one for next photograph during one of my visit in such cases. So there is hair oil, pesticide, and all are in the same day. So only one house. So with this experience, one of my prospective study We investigate the pesticide residues in the blood serum for any possible relationship with occurrence of ophthalmic tumor, especially malignant tumor. Materials and method, a case control study was carried out in northeastern region in our institute and one of our collaborative institute and B. Buddha Cancer Institute. In this study group, a total of 66 patients of childhood ophthalmic tumor were included. Equal number of frequency image controls were included. Ethical clearance from the Buddha Institute and written consent was taken from the parents. Study criteria inclusion only confirmed cases, either histopathologically or by bone marrow, and exclusion doubtful diagnosis and if lost for follow-up. Enrollment criteria is case are identified directly by the investigation. Controlled with frequency match age 6 from the same geographic area at least for 1 year. Those are the some patients of malignancy, those are confirmed by bone marrow biopsy or some others. All other investigations are the routine investigations for less standard cases of tumor, and only the diagnosis radiological, pathological and bone marrow. That our main part is that other methodology, the both blood sampling methodology, venous blood 10 ml, in some cases maybe a 6 to 8 ml considering the health of the patient, but ideally is a 10 ml in a 20 ml glass vials with a heparin put in 0.2 ml. It was in a minus 20 degrees centigrade. Ultimately, it was sent to that one of our institute, nearby institute for analysis. Blood sample were analyzed by gas chromatography method. This is the actually techniques for a gas chromatography in a one forensic lab. They are using for forensic purpose, but as for our request, they are doing this in our free of cost. So, out of 38 were male and 28 were female, the mean is the study and control group are 6.24 and 6.03. The main point is that residues, mainly those are lots of other pesticides, but still some DDT is one of the component in our part, and in the DDT is significantly very, very high, 762 microgram per liter, and in compared to the control, only 350. Controls are disease free, those are coming from the same locality for a refractive or some other reasons. And statistically, it was evaluated by pair 2 test, and it was found p-value is less than 0.003, which is significant at a 1% level of significance. Our data suggests possible link of pesticides in the etiopathogenesis of childhood tumor. This study has been designed to augment the spare information available to categorize the childhood tumors in northeastern region. However, the variety of environmental exposure that farming communities are very difficult to differentiate from others. But as most of our patients are from a farming community, so we consider that DDT is one of the components to verify that there is a difference between the control and others. And it is established factor for a childhood malignancy in some Western countries and African. And the Asians, there is a more orbital tumors, more ophthalmic tumors in malignant tumor, and incidence is slightly higher. So in such cases, there may be pesticide is one of the crucial factors. One of the limitation of our study is we cannot rule out other possible factor. Only we can evaluate the pesticide and we can document and we can identify statistically is a very, very significant, but there may be other cause also. So in future studies need to establish the mechanism by which pesticide influence the risk of orbital malignancy and to determine biological basis for this association. We want to conclude that this study findings strengthen the hypothesis that the use of pesticides may play a role in the etiological of childhood ophthalmic tumors. Those are some selective reference. Thank you.
For an excellent presentation and also for an insight into the positive role of the pesticides in ophthalmic malignancy. There, of course, is a possibility, and we need to be aware of such a possibility. And further studies will strengthen your observations. These observations have been made in the past too.
I'd like to know whether you have taken the pesticide as DDT alone, or have you looked for any other pesticide as well?
look for others also, but because in all our cultivator easily available, DDT is easily available as an insecticide, and to compare with the other control, we statistically we analyze only DDT.
In one part of Kerala, there is a lot of commotion going on regarding endosulfan spraying in the region, and there have been a lot of malformations in children, stunted growth, and a lot of other problems. Malignancy as such, the statistics have not been studied.
And in few areas of northern India, this DDT is banned, especially in our region in Punjab and Himachal. This is not used these days. I think in most part of the India, it is banned DDT these days. I belong to a farmer family. I know that this is banned product.
DDT is banned still. Often is from health department they are using once there's a mosquito, and it is easily available, low cost. They can use and easily available in some areas. Those are patients are suffering from malaria, etc. From a health department, there is a supply for till that is going on. So that's the reason.
Have you analyzed the type of malignancy which is most prevalent, like orbital?
Orbital is no. Yes, in this particular study, there is no such. We are include that both orbital malignancy and that ocular malignancy. But in case of orbital malignancy, that incidence is high in our part. That indicates that there is a definite role of this pesticide may because the malpractice is going on. So like this, so from a health, there is a DDT, and sometimes part is a very prone for malaria, but still is going on. So they collect it from that thing and is very easy to spray, and then it's.
So basically, we need to
society regarding the possible severe harmful effects.
Yeah.
So that even if it is banned, of course it is banned, but even if it is available easily and at cheaper costs, they should not go for it.
Yes.
Right?
Yeah. Because those people are mainly sufferers. They thought what they are doing. Some are little bit their own product, own eating the vegetables. They are not using the DDT, but for the selling they are using. But on the other hand, that kids are easily that because of the lack of education, and kids are exposed, and ultimately they suffer more. So that's for awareness. I tell.
Thank you, Doctor. Our next speaker is.
I'm presenting on the topic higher order aberrations, which are to be recognized as the second refractive errors in children whose amblyopia doesn't get corrected with full corrections and patching. So residual amblyopia, you need to look at some other causes which are causing limitation in vision improvement. Absolutely no financial interest in any materials or technology discussed in this presentation. We got interested in this entity by reading this article by Dr. Amar Agarwal. He coined a very useful term called aberopia, which is still not very well accepted all around the world. But Journal of Cataract and Refractive Surgery also published this article which says aberopia, which is a new refractive error, can identify an abnormality in such situations where vision is not improving, and after LASIK surgery, you find a significant number of patients having immediate improvement within 24 to 48 hours, which cannot be explained by any synaptogenesis, which takes place in amblyopia management after patching therapy or long-term adaptation with spectacles. He could correlate it with the high root mean square values obtained from wavefront analysis in this patient. This was negated by a publication in Journal of Cataract and Refractive Surgery, which was published earlier in 2003, where RMS values did not really correlate well with the improved best corrected visual acuity. And of course, the technology used in both these papers were different. Initially, it was Hartmann-Schack's abrometers followed by Shering's abrometers. And then there were multiple controversial reports, including one in Investigative Ophthalmology and Visual Sciences and American Journal of Ophthalmology, where there was some correlation with the higher order aberration and some non-correlation with the higher order aberration and their vision and refractive status of children. So we decided that we evaluate ourselves with a newer technology called eye trace technology, which is based on micro LEDs, which would do eye tracing for each individual ray passed in a sequence. We included patients who had normalized and also those who had residual amblyopia despite of best correction, 100% compliance, and compared the higher order aberrations in normalized, normal in the sense emetropic normal vision, as well as ametropic with normal vision, and amblyopic eyes who had ametropia or anisometropic amblyopia. We did not include patients who had strabismus or deprivation amblyopia, nor any patient who had any other ocular or neurological comorbidities. As you see, the complete ophthalmic examination followed by eye trace analysis was done, and we obtained higher order RMS for total aberrations, corneal aberrations, lenticular aberrations, and 27 Z values for each of these. So a lot of data was actually collected and was evaluated using the statistical test as mentioned over here. We had 47 patients in this study, of which 24 were absolutely normalized. That means they had a normal vision, though 12 had emetropia with normal vision, 17 plus 4 had ametropia with normal vision. Anisometropic amblyopia in 8 patients, and 6 patients had bilateral isoametropic amblyopia. We found total higher order aberration to be normal, that is 0.26 in normal children, which was similar to adults. Unlike previous studies, including the one by Dr. Titial, wherein one case report was presented at JCRS where there was increased amount of higher order aberration in children. However, in all the previous studies, they have used a different technology, while the evolved technology right now is eye trace technology. In normal emetropes, we found it to be on a similar amount, while in patients who had ametropic amblyopia and anisometropic amblyopia, it was higher, but ametropic amblyopia, the mean came out to be almost the same. So, we found total higher order aberration in terms of RMS values, root mean square values, in anisometropic amblyopia eye to be statistically significantly high as compared to normal. Our cutoff was 0.4, less than 0.4 usually belong to normal, and more than 0.6 almost essentially belong to anisometropic amblyopia eyes. But this is when we compared with normal eyes, but when we compared the anisometropic amblyopia eye with the other eye of the same patient, though the clinical difference was there, say around 0.2, it was statistically not significant because of small size of the sample. We also found out Zernike coefficient, around 27 of them from second order to up to sixth order, and we did not find any statistically significant difference in internal versus corneal aberrations in normal people. While in children who had amblyopia, there was a significantly high, as you see over here, internal aberrations as compared to corneal aberrations. Corneal aberrations, all 27 of them were normal in amblyopic eyes, while all internal aberrations were significantly high. So in conclusion, I think this is the first case series from India where eye trace system is used in children to evaluate the higher order aberrations. They are comparable with emetropic adults. Lenticular aberrations were certainly much higher in amblyopic eyes versus the corneal aberration, which is not reported finding as yet. From third to sixth order, in fact, all internal aberrations or lenticular aberrations were high. We feel higher order aberration needs to be looked at as a new refractive error in patients who are not improving despite of best correction, despite of full compliance, despite of patching, pharmacotherapy, maybe pleoptics. And when you go back and look at the retinas, everything look normal, then next thing to do is do a higher order aberration analysis and correct them with a new technology called as iScription, which are the lenses which can correct this kind of aberration, neutralizing lenses. Of course, we have these two patients wherein total higher order aberration was correlatingly higher in the eye which has got lower vision, as in this patient, as well as this patient who has got ametropic amblyopia. The eye which has got higher amount of higher order aberration had a lower vision recovery. And when you give them what is called as aberration neutralizing spectacle, 3 of these patients had a 1 to 3 lines improvement immediately after giving the spectacles to them. So probably higher order aberration is there to be looked at, and it is worth doing some work in this particular branch of management of amblyopia and come out with long-term results of higher order aberrations in amblyopic patients. Thank you very much for your kind attention.
Some questions. And one thing I wanted to ask you, that you have compared the prevalence of higher order aberrations in ametropic amblyopes who have not shown satisfactory improvement versus the emetropes who have normal vision. Is that right? So don't you think that it would have been a better idea if you compared it with emetropes who improved satisfactorily or who did not have amblyopia?
Now, in our normal category, we had all tropes, and we did not find any difference between the two.
Right.
Then we collected the entire group into normal, and then compared it with the hematotic with amyloid.
The second thing is that how does one order the higher order aberration neutralizing spectacles?
It is available from Zeiss. It's called as eye scription, and the technology required is use an eye profiler. As you see over here, in this particular photograph, you see this frame needs to be put up on the spectacle chosen by the patient. The eye terminal from Zeiss would take multiple photographs in lateral gazes, primary gazes, make sure that the centration is perfect so that the neutralization is not shifted, and then you have this kind of a report generated. This report to be fed into the instrument and then placed order along with the sphere cylinder manually entered, which is rechecked by the wavefront graph, and then around in 5 days you get the neutralizing spectacle, which costs around 5,000 rupees a tag for average refractive errors without transitions.
And the figure show?
Yeah, this particular is before eye scription and this is after eye scription. If you so higher order aberration before and then put the patient back on the wavefront. Yeah. So from 0.47 becomes 0.17 for this side of the blood.
You mean to say it corrects the internal aberrations?
It corrects both the aberration, but the internal aberrations are more in patients who have amblyopia probably. Few other studies where there has been controversy, but as I told you, eye trace was not used. And again, here it is eye profiler technology, which is quite different from eye trace technology. So we need a lot of standardization in wavefront technology itself. By far, eye trace detects the best, I feel.
Well, it could be one of the factors in patients who are not responding satisfactorily to amblyopia treatment.
So this is just one extra investigation you might like to do. We don't charge anything extra for that. It's just done by the...
So do they improve...
This patient, check the vision. You do put the trial frame, check the vision, and you will find 1, 2, 3 lines difference, but not consistently in every patient. Okay. Because of the eye profiler technology. I think that's not the best technology to do wavefront. Eye trace is better.
Sujeta from Pune.
The orbit session. There was a tie for the first place. There was a tie for the first place. All the papers were really excellent. It is shared between Aditi Pujari and Kasturi Bhattacharya from Guwahati. Aditi Pujari from the paper was Clinical Pathological Profile of Patients Undergoing Orbital Exenteration in Tertiary Eye Care Center.
Yes, I'm going to speak on how a smartphone can be used for diagnosis of severe ROP. I have no financial disclosures to make. As we all know, ROP is emerging as an important cause of childhood blindness, and we in India are facing the storm right now. Most important determinant of any ROP management, time consuming, it could be potentially subjective and can be a factor in medico-legal liability. So, it puts a potential restriction on the number of babies screened due to few number of ROP experts available in India. Telemedicine, we all know, is an emerging technology that involves capture of patient data for subsequent interpretation by a remote medical remote specialist. There have been various studies conducted in the Western world to establish the accuracy of diagnosis based on images by digital photography. But in India, there has been no published study comparing digital photographic diagnosis versus smartphone-based diagnosis. And additionally, in India, all the centers may not have a digital photographic tool available in each setup due to financial constraints. So the rationale of our study was that teleophthalmology model using transmitted images on a smartphone can play a very important role in taking care of vast number of babies by a single technician and a single trained ophthalmologist. We wanted to validate this model for diagnosis using smartphone as compared to RedCam. That was the digital camera which we used in our study. We included all the babies less than 2 kg of birth weight. However, we excluded the images, RedCam images, which were uninterpretable due to factors like small pupil, vitreous haze, etc. Also, we excluded the babies which were already diagnosed as having severe ROP or were already treated for ROP. babies were screened under topical anesthesia after taking informed written consent from the parents, and relevant data was noted down. The screening was done with the help of RedCam under topical anesthesia by a trained technician. We did about 158 eyes of 79 infants, which meant 117 screening sessions. So totally 1170 retinal images were used to diagnose the severe grade of ROP. 14 screening sessions were excluded from the final analysis due to poor image quality, or they were already diagnosed severe ROP cases. The remaining 206 eyes of 103 screening sessions were included for our analysis. We took 5 standard images of the retina of all quadrants. We followed the IC ROP classification for the ROP. The same set of images was uploaded via internet on a server using this particular software called as I2I software, which was developed by a Bangalore-based company. These were the standard 5 images that we took for each eye. So coming to the flowchart of the methodology, the first ophthalmologist made diagnoses based on the images which were viewed on the RedCam monitor, whereas the second ophthalmologist accessed the same set of images on the smartphone screen to make the diagnosis. So basically we compared diagnosis based on this monitor versus based on this screen. Both the ophthalmologists were masked to each other's finding. They underwent inter-observer variation test before actually starting the study. All the babies diagnosed with ROP were classified as either severe or non-severe ROP. Referral warranted ROP was defined as a severe ROP in our study. Coming to the results, out of the total 206 screenings, 30 babies were diagnosed to have severe ROP by RedCam method, whereas 27 babies were diagnosed to have severe ROP by phone method. So severe ROP diagnosis rate by RedCam was 14.5%, whereas the same by iPhone method was 13%. So smartphone was found to have 90% sensitivity and 100% specificity as far as diagnosis of ROP was concerned. The positive predictive value was 100% and negative predictive value was 98%. This means that telephonic transfer of RedCam image is a good screening tool for diagnosis of severe ROP. Any eye declared as not having severe ROP by phone method has a very less likelihood of actually having a severe ROP. So to conclude, in a developing country like ours where accessibility to the healthcare is the biggest problem, smartphones can be used as a tool to prevent this ROP blindness. A single team of trained ophthalmologists and technicians can take care of a vast number of babies, and on this basis we could potentially suggest public health approach in strengthening the eye care of preterm babies. Thank you very much.
Thank you, doctor, for nice presentation. There is one set is the video interactive thelmoscope. You can take the images with video interactive thelmoscope, then you can transmit those images to your smartphone or to the ophthalmologist sitting at the tertiary care hospital.
But the disadvantage would be, in that case, the ophthalmologist would have to travel a lot doing screening. With RedCam, a technician can take the machine and travel even in the rural areas, and ophthalmologist sitting in the city hospital.
But RedCam is not available everywhere. It is a very costly.
So that is the advantage. One RedCam can take care of multiple centers.
Okay.
Country is kind of lacking behind what we actually need to do. So this is a very good step into making the screening process simpler and cheaper. And let's see how far we can make it more acceptable to the people who are involved in it.
Definitely a 19-innovated technology has to be put into practice. I think it has to come soon. Very good.
Thank you. Prematurity. Retinopathy of prematurity or Terry syndrome, previously known as retrolental fibroplasia, is a disease of the eye affecting prematurely born babies generally having received intensive neonatal care. Caused by disorganized growth of retinal blood vessels,
which may result in scarring and retinal detachment. Both oxygen toxicity and relative hypoxia can contribute to the development of ROP. As such, all preterm babies are at a risk of ROP, and very low birth weight is an additional risk factor. ROP can be mild and may resolve spontaneously, but it can lead to blindness in serious cases. Refractive error are common following both full-term and preterm birth, but preterm tend to be more myopic and astigmatic than full-term infants. Preterm birth, low birth weight and increased severity of acute phase retinopathy are known risk factors for development of strabismus. The aim was to study the prevalence of ocular sequelae like refractive error, strabismus and other ocular morbidity in preterm children diagnosed with retinopathy of prematurity. It was a retrospective study done at a tertiary eye care center in southern India. All preterm babies who were referred for screening with the evidence of ROP and a minimum 5-year follow-up were included. A total of 99 babies, that is 198 eyes, were documented the presence and staging of ROP. Best corrected visual acuity was taken in the last visit. Cycloplegic refraction anterior segment examination was done. Orthoptic evaluation by Hirschberg's corneal light reflex test and fundus examination with indirect ophthalmoscope, the 28 diopter lens with scleral indentation. Preterm neonates who didn't have any evidence of ROP or children less than 5-year follow-up were excluded from the study. Coming to the results, of the 99 babies, 61 were males. They had a mean gestational age of 30.85 weeks and mean birth weight of 1.42 kgs. Best corrected visual acuity was 6.6 in 40% eyes. Myopia was prevalent in 59% of the eyes, hyperopia in 2.5% and emmetropic was 38.4%. Coming to the anterior segment sequelae, pseudophakia was present in 3.6% of eyes with posterior chamber intraocular lens. 23% had strabismus, 5 being esotropic, 9 of them being exotropic, few had nystagmus with or without strabismus. ROP had regressed in 86.2% of the eyes. PRP was done in 49%. Coming to the discussion, mean gestational age at which ROP was seen was 30.8 weeks and mean birth weight being 1.42 kgs. 59.1% had a myopic shift, 2.5% were hyperopic and 38.4% were emmetropic. 82.88% of these children had a visual acuity better than 618 and 0.5% had no PL. Among the Asian studies, Verman M. et al. Studied 50 preterm infants and showed that at 1 year of age, 64% had normal vision, while incidence of myopia and hyperopia was 16 and 20% respectively. While Kim J. Y. et al. Studied 99 premature infants at 6 months of age and the incidence of myopia in premature infants was 36.3%. Zhu and E. Gallo et al. Published in British Journal in 91 showed a close association between regressed ROP and myopia, particularly between severe forms of regressed ROP and high myopia. It also showed the prevalence of strabismus was 38.8%. Regressed ROP was seen in 45.8%. Thus, most children, when detected and treated early, would gain near normal vision. Amongst the anterior segment sequelae, 33.6% were pseudophakic with a posterior chamber intraocular lens, 90.4% eyes were within normal limits. 23% had strabismus, 5 had esotropia, 9 of them with exotropia, and few children had nystagmus. A study which was done by Deborah K. Vanderweel et al. And published in JAPOS 2011 showed that most children with a high-risk pre-threshold ROP develop strabismus at some point of time during the first 6 years of life. And the risk factors for this were abnormal fixation, history of amblyopia, anisometropia, and unfavorable structural outcome. This study highlighted the complexity of attempting to understand the pathogenesis of strabismus in a child born prematurely. Dawn L. Brenner, published in Arch Ophthalmology 98, showed that total prevalence of strabismus in the first year was 14.7%. 50.78% of ROP babies underwent panretinal photocoagulation, 5.2% underwent vitrectomy. ROP regressed in 86.2% of the children, and 5.5% children developed retinal detachment with sequelae. The high frequency of regressed ROP in our study strongly indicates that prematurely born children are an ophthalmological risk group with increased incidence of refractive errors, strabismus, and retinal complications. They must therefore be carefully followed up during the period of visual development in order to prevent visual dysfunction by intervention as early as possible. Thus concluding, multiple sequelae were seen in ROP babies with long-term follow-up, and hence long-term follow-up is very important in ROP babies for a good visual outcome. Pediatricians and ophthalmologists must thus continue jointly to investigate the condition that predisposes to ROP in the hope of preventing or at least diminishing the severity of the disease. Thank you.
Thank you. It was a nice presentation. And roughly how many patients, like you said the number was 99, you reported that.
99 babies with 198 eyes, sir. And
What stage of ROP?
sir,
Or those who required treatment?
no, sir. It was some even were observed because they were in the initial stages. It was at all stages of ROP, but some evidence of ROP was there.
Okay, so it may be stage 1 also.
Yes, sir.
How many
Because, sir, it had
children were
almost 5
screened
to
to
10.
get these 99 patients as ROP
Pardon,
at
sir?
some stage? How many patients were screened to get these 99 patients?
Sir, actually, I had taken this from 2003 to 2008. So I had almost gone through almost some 2,000-3,000 registers to collect this sample size, sir. And because some of these children who were stage 1 and 2 were observed, but then they regressed, so they didn't come back. So I wanted to take a follow-up of 5 to 10 years. So I have had children who come for follow-up at 10th year, and I have seen them at what stage they were in.
Yeah, I know it is painstaking to have a long-term follow-up in any study.
But sir, then the study, the effectivity of the
So
study.
what point I wanted to make was it is a very small percentage of children who require actually treatment in ROP. Depends on the birth weight and birth age. But by and large it is around 3 to 5% of children require treatment.
I think probably your baby weight was 2,000. Most of the studies are 1,500. Maybe that is also showing a less number of patients with strabismus or requiring treatment.
Baby weight was 1.42 on an average, ma'am. Yeah. Because I had not taken all preterms. I had only taken with evidence of ROP. So I had average.
Like, so it is on a borderline of screening criteria.
Yes.
The lower you take,
The greater it will be, yes, sir.
So she has basically screened for the sequelae of ROP.
Yes,
right?
Yes,
and in your sequelae, you have come out with strabismus,
yes,
residual myopia more than residual hypermetropia.
Yes,
is that right?
Yes,
retinal detachment,
yes,
and some patients developed cataract who have been operated.
Yes, ma'am.
Is that clear? I want to know that the strabismus that you are talking about, did you leave it at that, or do you think that strabismus was related to poor visual status? Probably that. Or poor visual status was separate from strabismus. You have not talked about poor visual status as a sequelae.
Actually, ma'am, the strabismus that we had seen, a lot of them were intermittent XT, so their visual status was good. But there were few wherein, I have not mentioned over here because of time constraints, but yeah, there were few where the vision was less and that was the cause of strabismus, like the sensory strabismus.
Because one of the important sequelae would be a compromised vision.
But then when we saw, we almost had greater than 60-70% of the children who had almost 82% where the vision was better than 618. So,
right. Yes, of course.
Was there any, like the strabismus, was it more common in patients who had more asymmetric ROP, one eye stage 1 stage, or strabismus higher there?
So we'll have to go back and check that, sir, because I had not taken that as those criteria for this thing. But yeah.
Was there any correlation with the prematurity or birth weight versus the type of defect that they will have in the ocular system? Lower the weight, higher myopia, or lower the weight?
So lower the weight, greater chance of having a greater severity of ROP and greater the chance of myopia, sir.
So was that correlation?
Yes, that was there, sir. That was there.
Outcome of pediatric cataract surgery using preservative-free triamcinolone acetonide.
My topic is outcome of pediatric cataract surgery with primary posterior capsulotomy and anterior vitrectomy using intraoperative preservative triamcinolone acetonide. Just a brief introduction about, we know the developmental amblyopia is a major concern in the management of pediatric cataract surgery, even after early surgery, due to the inevitable complication in the form of PCO. So an elective posterior capsulotomy followed by anterior vitrectomy under 6 years of age is an universal consensus to prevent PCO. During anterior vitrectomy, identification of the vitreous is an important factor for better surgical outcomes because the vitreous which are remaining can increase the chances of infection, inflammation, pupillary irregularity with opacification of the posterior capsule. The objective was to evaluate the intraoperative and postoperative outcome of pediatric cataract surgery with PPC and anterior vitrectomy using the intraoperative preservative-free triamcinolone acetonide. Mitigation methods: we enrolled 20 children between 2 to 8 years of age having either bilateral congenital or developmental cataract. Each of the 2 eyes were randomly assigned to either study group or control group. Group A comprised of 20 children, 20 eyes who underwent phacoaspiration followed by PPC plus anterior vitrectomy receiving intraoperative intracameral triamcinolone 4 mg in 0.1 ml with IOL implantation. In the group 2, we did the same procedure except we did not use intraoperative triamcinolone acetonide. The study period between the Jan 2011 to Jan 2012. Each child was followed for a minimum period of 6 months. Our exclusion criteria were: we did not include any congenital anomalies such as PF, persistent vasculature, TRDs, aniridia, children with traumatic cataract or subexudated cataract, child with colobomas, complex maculophthalmos, and cases where IOL has to be implanted in the sulcus. Ocular examination included preoperative visual acuity wherever possible was done, visual access, fixation preferences, pupillary reactions, and intraocular pressure. Document the type of cataract after dilating the pupil, and the fundus evaluation. The axial length was measured using A-scan, ultrasound, and keratometric readings. Alpha was calculated as per the Hung guidelines using 10% undercorrection between 2 to 8 years of age. In group A, after removing the lens matter, we did PPC, and after doing PPC, we used 0.1 ml of triamcinolone to stain the interface of vitreous. We did anterior vitrectomy, and followed by that, we implanted the IOL. And after implanting the IOL, we again injected the 0.1 ml of triamcinolone to stain the residual vitreous which are remaining in the anterior chamber. And we again perform anterior vitrectomy if there is any residual vitreous present in the anterior chamber. If there was no vitreous, then we remove the remaining triamcinolone from the anterior chamber. Now coming to the results, in our study, because we have same age group and same number of children having bilateral cataract, so the mean age was same in both the groups and the gender distribution was same in both the groups. The mean value of postoperative intraocular pressure was 14.95 mm in the group A and 14.60 in group B, which is not significant in either groups. As you can see in these graphs, there is hardly a difference between the two groups. Coming to the cellular reaction, we grade the cellular reaction based on the Sun classification. The reaction was 1 plus in 16 eyes and 2 plus in 4 eyes on day 1 in study group. In control group, the reaction was 1 plus in 5% in 1 eye and 2 plus in 14 eyes and 3 plus in 5 eyes. So the difference between the two groups was highly significant in early post-op days. However, at 2 weeks, the reaction was nil in the study groups in all eyes, while it was 1 plus in 4 eyes and nil in 16 eyes at week 2. However, at subsequent follow-ups at 3 months and 6 months, the reaction was nil in both the groups. This is the first post-op day photograph of the study group where we used triamcinolone acetonide. You can see the minimum cellular reaction and the pupil is round and regular. Come the posterior synechia, it was seen only in 1 eye in the study group, it was not seen in the control group on day 1. The pigment deposits on the anterior IOL optics was seen in 2 eyes in the study and no deposits in the 18 eyes in the study groups, while in control groups the deposit was seen in 14 eyes and no deposit was seen in the 6 eyes. So the result was significant in the 2 groups. This is the photograph of the patient in the study groups you can see the minimum pigment deposition and the pupil is round and regular. As compared to this photograph where we did not use the triamcinolone, there you can see the significant pigment deposition obscuring the visual axis. The pupil was regular in all eyes in study group, however in control group, the pupil was regular in 18 eyes and irregular in 2 eyes. The PCA was seen in 2 eyes in the control group and none occurred in the study groups. This was a photograph of the control group. We can see the pupil, the peaking of the pupil in the temporal area at 3 o'clock. In this case, we don't do triamcinolone. So, for coming to discussion, in the present study, the end-segment inflammation was more in the control group as compared to study group. Also, the pigment deposition was more in the control group as compared to study group. So, this suggests that the triamcinolone acetonide might help in complete visualization of the vitreous and increases the surgical better outcome. So, to conclude, we found that the triamcinolone acetonide, which is preservative-free, it enhances the vitreous visualization during the surgery, resulting in less inflammation, regular pupil, and less pigment deposition on the IOL surface. Thank you.